I started out as a family practitioner. I did 1 year of family practice and realized that there was a great desire to, or a great love of delivering babies. And the gynecology, I just kind of fell into because it was required. But as time passed, with the technologies and innovations that were occurring, there were so many things occurring with gynecology, it just piqued my interest. So I just always tried to stay on the cutting edge. So we went from opening most people for a hysterectomy to minimally invasive, and then came the robots. The United States, over 600,000 hysterectomies are done each year. And the majority of those are for benign or non-cancerous issues. From a guy who trained back in the late 70s and 80s, most of our surgeries, hysterectomies, were done open. What I mean by open, a scar on the abdomen, either north-south or east-west. And those women typically were in the hospital for sometimes 3 to 7 days, and they got infected, they had blood clots. So it was a way of doing a hysterectomy, but there was a certain amount of morbidity associated, meaning complications. As we progressed, and that's the beauty of medicine, there's change. Most of the change is good, and you adapt. Some change, you need to leave alone or walk away. We move towards what's called minimally invasive surgery, wherein we're talking about tiny incisions, maybe an inch, but majority of the minimally invasive surgeries require 3, 4, 5 1-inch incisions, and in some cases that's needed, but the technology with robotics progressed to the point where you could do the surgery through one 1-inch incision. The greatest amount of explaining or the obstacle I have with talking to patients about robotic surgery is to inform them that the robot can do nothing without me sitting there directing it. It is not pre-programmed. It is not R2-D2 or any free roaming robot with me sitting in the lounge drinking coffee. I have no shame in saying cosmesis. We're going to accomplish the same procedure, but through a 1-inch incision inside the belly button. So the choice is, do I want 3, 4, 5 small incisions, which is good, versus 1 incision. If I can get 1 incision and don't sacrifice the technology or the quality of the operation, I would think that patients would want to have that done. And there may be patients out there who would say, and on occasion I'll have somebody who would say, well, I just don't want any kind of computer or anything around me, open me up. The challenge is to convince those patients that the technology is better. So again, 1-inch incision versus 3, 4, or 5 incisions.